We remove endometriomas for pain. Okay. And I do that after people have seen a fertility specialist. And I think it's super, super important for people to be aware that surgery prior to fertility, if they want to have kids, is probably going to decrease the amount of eggs they have left. And going into that with that understanding is really important for a patient, because more things that we can arm a patient with in terms of information and knowledge is so, so important for them to be able to make the decision. Because this is not my life. This is not my child that they're trying to make. They're trying to have their baby and they're trying to improve their pain. And if they have all of that information before we operate, so much better.
Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're two of the physician leaders at Markham Fertility Center, otherwise known as our baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together.
On today's episode, we are very excited to be joined by Dr. Jeff Zeni again. He is a gynecologic, minimally invasive surgeon who works often with our patients here at Markham Fertility Center. And we're so excited to talk about endometriosis and fertility and endometriosis and different fertility treatments.
Dr. Zeni was with us during episode number 3, if you want to go back and check that out. And we had such an overwhelming response that we had to bring him back. Welcome back, Dr. Zeni.
Thank you guys so much for having me. It's my absolute pleasure. And it means so much to me that you guys actually trust me with your patients in terms of taking care of your patients to their surgical journey as a component of their fertility treatment.
So let's now talk about infertility and endometriosis. Let's get into it. As an endometriosis surgeon, what does the evidence tell us about the role of endometriosis in 2 ways, in spontaneous conception and infertility, and in the success of an IVF cycle or a frozen embryo transfer? It's a bit of a complex question, but I think we should separate it into those 2 categories.
I think those 2 categories are really important to separate into, right? Those 2 goals are very different. I think they're different for the patient in terms of experience. Huge difference in terms of experience for a patient going through IVF or IUI as opposed to natural conception, but also in terms of cost, right? There's a lot of out-of-pocket cost. Even for funded cycles in Ontario, you're still paying for drugs, right? And there's a lot of places where IVF cycles aren't funded by the government, right? So the out-of-pocket cost for fertility treatment is really big. And it's a very precious resource in terms of being able to get these eggs, make these embryos. So optimizing things for both is really important. And those optimizations are a little bit different. When I talk to patients about how endometriosis affects fertility, I break it down to different things. We talked a little bit about how fallopian tubes affect fertility. And that is the best evidence we have with regards to endometriosis and fertility and surgical management. So if we surgically manage people who have what we call hydrosalpinx, which is a fancy doctor word we use to make ourselves sound smart. And it just means there's fluid inside of fallopian tube. Always drives me nuts how we want to confuse people by using a whole different language. But when we remove that fallopian tube that has a whole bunch of fluid in it, we can actually improve both natural conception rate if they have another open tube, or IVF conception rate for somebody who's going to do IVF with an embryo transfer, regardless of kind of all of the other factors inside the pelvis. So that's number one. You have a big dilated tube. That's something that we really need to talk about in terms of trying to optimize things if you want to get pregnant. The murkier waters are what come next, right? The evidence that is not as good. And I break this up into the 3 other categories, right? Superficial endometriosis, deep endometriosis, and ovarian endometriosis. And when we're looking at superficial endometriosis, there was a big study that was run in the 90s, which showed that all comers treatment of superficial endometriosis improves natural fertility rates for 6 months to a year after they end up having their surgery. And people have taken that and they have run with it as far as they possibly can, because in that study, they did not split excisional surgery from ablation surgery. So it gave people all this permission to do ablation, and people get pregnant. Like, it's not wrong, right? The evidence, we see that in the clinic a lot of the time, right? We do surgery, people come back like 3 months later, and I'm seeing them for their first obstetrical appointment, right? And they had natural conception, 6 weeks after surgery. That's not how it always goes. This is not 100%, right? We treat your superficial endometriosis and you have no other cause for your infertility, right? We have to think about, male factor or other causes that are of infertility that are there as well. If there's no other cause other than that superficial endometriosis, we take it out, you're not guaranteed to get pregnant, right? Your chances might go up, but there's not going to be a guarantee. Superficial endometriosis resection in IVF is more murky. There's studies that say, maybe there's an improvement with excision only. Some of them, they're like, actually no improvement in terms of IVF. And the theory of why there might be an improvement with removing both deep and superficial endometriosis with IVF is that it's decreasing the global inflammation inside the pelvis. And that global inflammation decrease is providing a more hospitable environment for implantation. And there's a lot of stuff that's happening in fertility with inflammatory markers, and you guys are actually amazingly at the forefront of all this stuff, looking at inflammatory markers and how that might impact implantation and eggs and egg quality and all these different things. When we look at it with endometriosis, the jury's a little bit out. If you've tried and you've had euploid, which is a genetically normal embryo, put into the uterus, and maybe you've tried 2 of those and neither of them have taken, or you've had early miscarriages, then there might be a role for excisional surgery going in, removing the deep and superficial endometriosis to decrease that inflammation within the pelvis. And we really need more research to say if that's going to be something that we should offer everyone, or if it's going to be a case by case. And I think we really have to talk about the fact that the evidence just isn't there yet, right? We don't have that perfect slam dunk in terms of, yes, this is going to improve your chances. Maybe not make everything perfect, but it will improve your chances. We just don't have that yet because the evidence right now contradicts itself. Then we look at ovarian endometriosis, and that's like a whole nother bag of worms, right? With ovarian endometriosis, people have talked about egg reserve, like total number of eggs. And then people are looking at AMH, intrafollicle count, which is, those are surrogates for looking at how many eggs are there that can be used for IVF retrievals. And then looking at egg quality, which is how good are those eggs at making a normal embryo that's going to implant and turn into a live pregnancy. And when we look at ovarian endometriosis, they're like, total globally, there's decreased egg reserve. And when you actually separate that out and you tease out the evidence, the decreased egg reserve is the people who had the surgery first. Okay. The people who had surgery, that skews the numbers enough to say that as a general whole, people who have an ovary with ovarian endometriosis within it are going to have a lower egg reserve. So in my clinical practice, if somebody is really interested in trying to get pregnant, they have ovarian endometriosis, first step, fertility clinic for egg retrieval, creating embryos or freezing eggs before we operate to try and get the best chance of the most number of eggs. And people are going to talk about egg quality and, decreasing egg quality with an endometrioma there. And there's evidence where they look at the microscopic levels of how the endometrioma causes this inflammation, causes these other reactive changes around where the endometrioma edges are, decreasing the eggs there. But keeping in mind, when you remove that cyst, you're damaging all of that ovary as well. So that quote unquote, maybe improvement in egg quality is not a true improvement of egg quality, because all those eggs you were going to improve, you actually damaged on the way out.
That's right.
So when you tease apart that evidence, you don't see the improvement of egg quality after you do the endometriosis surgery to remove the endometrioma. We remove endometriomas for pain. Okay. And I do that after people have seen a fertility specialist. Mm-hmm. And I think it's super, super important for people to be aware that surgery prior to fertility, if they want to have kids, is probably going to decrease the amount of eggs they have left. And going into that with that understanding is really important for a patient, because more things that we can arm a patient with in terms of information and knowledge is so important for them to be able to make the decision. Because this is not my life. This is not my child that they're trying to make. They're trying to have their baby and they're trying to improve their pain. And if they have all that information before we operate, so much better. Because I don't want a patient to ever have to come back and feel like, we did this surgery, we didn't talk about my egg reserve beforehand, and now I can't get any ovulation or any good eggs out of my ovaries. They just don't stimulate well with IVF. I can't get pregnant on my own. And that's not the goal. The goal is to try and optimize both these things synergistically. And I think the interaction between fertility specialists and surgeons needs to be there so that we can do that in a really informed way for patients.
I think that really speaks to the importance of this, like, open communication. And even though I've known you for a long time, having this conversation is fantastic. It's phenomenal to hear how you counsel your patients about it, and it's become more informed to hear about the newest things. Because for sure, I'm still thinking in terms of the classical ways, which I think you talked about before. And so this is really, really helpful.
You're right. You talked about access. We're very lucky here at Markham Fertility Center that we have you just downstairs from where we are. Markham Fertility Center has their own OR time. You have your OR time. We really work well together. Our physicians come and assist you in the OR when you do endometriosis surgery in our patients. So I really feel that's the way it should be. Unfortunately, it's not saying anything badly about other clinics. It's just there's just no access anywhere else. There are not that many surgeons out there. The waiting lists are really long. Many of the clinics are not really working closely with endometriosis surgeons just because of the setup, not because of any other reason. And yeah, it really is too bad. But I wanted to go back just to clarify. So there's a patient who's done IVF and has diploid embryo transfers, and she hasn't done an embryo transfer yet. And let's say she has done endometriosis mapping for whatever reason, and there is some endometriosis. Let's say she has, 4 euploid embryo transfers, and she hasn't done an embryo transfer yet, and does not have a hydrosalpinx, a swollen fallopian tube. Do you think a patient like this needs to have endometriosis surgery prior to her first embryo transfer?
So I'm going to go back for one sec before I answer that question. First of all, you made me blush, and thank you very much. I appreciate all those very kind words. I think the relationship between the surgeons here and the fertility specialists is something I've never seen anywhere else before, and it is absolutely incredible. And I think it provides such better care for the patients. And that makes such a huge, important change from the classic way it's done, where there's like this island of fertility specialists and there's hospitals that have surgeons and they like refer each other, but they never actually really talk and they never really work together and they never benefit from each other. But here it's such a synergistic relationship. It's absolutely fantastic. And I feel so lucky and privileged to be here to work with you guys, as well as work in this hospital setting that like really is so happy to provide that for the patients. And we can't say enough about Markham Stouffville, which allows us to work together to treat these patients. It's awesome. Now I'm going to get back to your question. Just to summarize, we have this patient. She has endometriosis, which we've seen on ultrasound. She probably has pain. She has her primary goal of getting pregnant, and she has done an IVF cycle before any surgery, and she has 4 euploid embryos frozen, waiting. And those embryos are genetically normal. That's what euploid means. And the endometriosis world don't talk about euploid all that often. But the fertility world, it's like your vernacular. So in those circumstances, I think there's a couple things about this question that are really actually specific and that we need to think about when I talk to my patients about this. One is there's 4 embryos, right? So if you try one transfer and it doesn't work, we also have the opportunity to do surgery after that transfer before the other 3, right? If you try that transfer and it works, you're pregnant and that's your primary goal, and that's fantastic. And then we can do surgery after you're done having your children. And then we don't have to have such a concern about that ovarian reserve component of the surgery. So that's different than somebody who only has 1 euploid embryo, because that single euploid embryo is like this diamond that is being cherished because it's the only one they have. And I'm not saying that 4 euploid embryos are not important, or the one of the 4 is not important. It's very important, but it gives a little bit of leeway where you don't necessarily need to go through the risk of surgery beforehand. Whereas if there's only that one euploid embryo, I think that counseling is more nuanced in terms of maybe we should give this embryo the absolute best chance it can get. And then maybe surgery might be warranted beforehand. But there's other factors always at play in these things. They're never as simple. Patients are all so different. And that's why the counseling needs to be so personalized for all these patients. That's why when you guys send me a patient, our first consult is always over an hour, right? There's so much to talk about in terms of all these different components. And that's before you get into the ultrasound. And then we have a huge another conversation after the ultrasound's done. So, a lot of this counseling is with trying to get at what the patient's goal is, what their real at the end of everything, what they want, right? And where their values lie, and how do we best achieve that and help them to achieve those goals. They're not our goals. If somebody has horrible pain, all they want to do is have a baby, that's very different than somebody who's like, my pain is so bad. If I have to not have a kid, then that's fine, but I just need help with this pain. And we've talked so much about surgery, but there's also medical management, right? And sometimes we can temporize people in terms of pain management with medications before pregnancy and between pregnancy to try and get them to that point where they can have their babies and then operate when there's less risk to decreasing the ovarian reserve afterwards. But on that situation with 4 embryos, I would tell the person probably go ahead, try an embryo transfer. If you don't get pregnant, come back, we'll talk again. If you get pregnant, that's fantastic. That's exactly what we want to hear, right? And then we can reassess things after your pregnancy. If you want to get pregnant again, we can talk about what we're going to do next and what we're going to do in an interval between your pregnancies and things like that. So lots of options.
One of the things that I kind of struggle with conceptually is a person, let's say, where they're known to have endometriosis and they want to start trying to conceive naturally, right? So on one hand, we know that a person who wants to try naturally with no endo, probably if you do surgery, they have better natural fertility afterwards for a limited time period. But at the same time, we worry about doing surgery in them because we know that it may potentially comes with risk. It may potentially affect their egg reserve. And I feel like I end up in this catch-22 in my mind of how to counsel that patient who may be just at the start of their fertility journey with known endometriosis.
I think I have this conversation more often than you guys do, because this is either when I decide to send them to you or I'm like, you guys got to start trying, right? Like, so infertility is more prevalent in people who have endometriosis, but there are people who have horrible complex disease who get pregnant naturally. And all of us turn our heads and we're like, how did that happen? Right? But it happens. And you're never going to know if you have infertility until you actually try and conceive. And I think that's such an important component for people, right? I think going through surgery before you start trying is putting the cart before the horse. I don't know.
Yeah.
I'm bad with analogies, but you're kind of getting ahead of yourself. More often than not, you're going to not have problems with fertility, right? And that's fantastic. If you do have issues with fertility, then we have our options in terms of having our fertility colleagues counsel our patients, potentially do IVF, do egg retrievals, embryo formation, egg freezing, whatever it ends up being prior to surgery, or surgery prior to trying to naturally conceive again, or a combination of the both, because those don't have to happen in isolation, right? You can do an IVF cycle, come back, do your surgery, and then naturally conceive. And, you're like, oh my gosh, like I spent all that time and all that money doing the IVF, but the catch on the other side is what happens if you don't end up getting pregnant with the natural conception? And now we've done the surgery, your ovarian reserve is lower, your IVF is going to have a lower yield, you have a lower chance of long-term pregnancy. It's an insurance plan. And that insurance plan, I think, is really important for people to go into with really, really good informed consent, because that patient gets to make that decision, not us. And when I talk to the patients that you guys counsel, it's always such a breath of fresh air, because you guys always talk to them about all these different nuanced pieces of this. So they actually get to make that really informed decision. And I love that. And the patients really appreciate it. And I think that's the ideal scenario.
Another case that I want to talk to you about, another thing that I find difficult is sometimes you have patients that come to us for infertility, very minimal pain, no diagnosis of endometriosis, maybe a bit of male factor, maybe unexplained infertility. And of course, age is a big factor, time is a factor, the clock is ticking. They do IUI, it doesn't work. You move them to IVF, they make embryos, maybe they have a miscarriage, maybe they have an embryo transfer that doesn't work. And now you've gone through this journey, it might be a year, it might be 2 years. There might have been 1, 2, 3 embryo transfers, 1, 2, 3 IVF, depending on so many factors. And then they might say, I saw on the internet about endometriosis, or I heard about this. Can we look into it? And I always said, of course, I know somebody amazing who can talk to you about it. His name is Dr. Zeni. And then I make the referral. You're always so great about seeing them as soon as possible. You do your amazing mapping, endometriosis ultrasound, and lo and behold, there is endometriosis. And now the question is, should we have referred them earlier? Should we not have done those IVF cycles? Should we not have done those embryo transfers? What would you say in a case like that? I struggle with that because one point is like, you're in front of me, pain is not an issue. You want to be pregnant. You might be 37 years old. You might have ovarian reserve that is so. We did an IVF, we got 2 embryos, great. We did a transfer, it didn't work. We did another one, miscarriage. Okay, that's great. Great as in, we know that we can get in there. We did another cycle. Maybe we got some euploid embryos, almost 6. Like you're kind of almost there. And you want to get them to if I just put this right embryo in there, we're going to get them in. There is the immune testing that we do. There's the hemolysis that we do. There's so many other things that we do outside of surgery to get them to that goal. And then sometimes you end up with this diagnosis and they end up in the OR table with endometriosis. And the question is, at what point should a patient on a fertility journey be referred for endometriosis with the understanding of the wait time, the understanding of the evidence that we know about endometriosis without the presence of a swollen fallopian tube, with the understanding of the risk of surgery, with the understanding of the impact of ovarian reserve, and the impact of waiting and not having a fertility treatment or an embryo transfer or whatnot in the long-term outcome or the long-term desire of having 1, 2, 3, 4 children.
It's a nice loaded question. Thanks for that one. I love how you guys started with the easy ones. You just slap that on. I appreciate that, baby.
But that is like the crux.
That is it.
Well, I know. It's brutal, though. It's
that
brutal.
is the crux,
It's so easy to
actually,
say in retrospect.
of what we struggle with, right? And I agree. Sometimes I wonder, should I have sent them earlier? But again, you hit the nail on the head. Time to get to see an endometriosis specialist, and then time to get the ultrasound done for endometriosis, then time to get into the OR and potentially recover from OR to be able to move on, right? And again, if a patient doesn't really have symptoms, like you mentioned in this scenario, there wasn't really significant pain, that may not trigger me to think about endometriosis at the beginning or when we're doing IUIs or when we started with an IVF, right?
Yeah.
And it's not uncommon for patients with fertility. They just really want to get pregnant. So in my first consult, I always ask, pain with menstruation, pain with intercourse. Yeah, I guess I take some Tylenol, some Advil here and there. Is not a big deal because all they really care about is get me pregnant now. They're not thinking about their pain, right?
Yeah.
And sometimes when you go through fertility, you take all these hormones, the ovaries are being overstimulated, and now you become very hyper aware of your body. And I know because I've been there. Now you know when you're ovulating, you know when this is happening, what's happening. So then pain becomes a bit of an experience that they have, that they think about a little bit more because they're now hyper aware of what's going on in their body. And then at some point in that journey, it's actually, I'm having a lot of pain with my period, but a lot of time, and rightly so, fertility patients are minimizing their own pain because they just really want to get to pregnancy. That is their goal.
I think the other huge component to why people minimize their pain is because they've been gaslit for their entire life since their first period, right? I see this all the time in my office where nobody is ever taking their pain seriously. So people stop talking about it. And it is so sad for me because if men had the same problem, there was no way anyone would shove this under the counter. Nobody would be like, oh, okay, this is just your period, right? Sucking up, everybody's periods are hurt. That's just what you have to go through. Nobody would ever say that to a man. Women are just expected to deal with it. And it makes me so sad, honestly. And you guys see it because they've been dealing with this for a long time. So they minimize their pain when they come and talk to you, which they've probably been doing for a decade, right? Part of this is why it takes people so long to get a diagnosis. But the other part of this is a huge societal issue, I think, that we still have, where people gaslight women all the time. It's just a reality. And people gaslight women about pain, and it makes me furious. And I rave about this to my wife all the time. And she has no interest in chronic pelvic pain. She says that. She's like, yeah, when we were young and you ended up having pain with the periods, people just said, yeah, it's a period, that's just what they're like. But periods aren't supposed to be painful, right? And when you tell patients that, and they're like, you mean periods aren't supposed to be painful? Everybody's always told me this is what they're like. So they just think that their periods are normal because people have told them that. And I think we've done a huge disservice to so many women in our society. Sorry, there's my little soapbox moment.
That's okay. I wasn't going to let you get away with not answering my question.
I'm coming back. So I love this question.
This is why podcasts are fun though, right? Because you can have that little soapbox moment. I mean, we've done it for sure. We've had our soapbox moments already.
You guys see the steam coming out of my ears? But yeah, I love this question because I was going to ask you the same question, and now I'm stuck with it because you guys beat me to the punch. But I think retrospect is always so much easier when you've done all these things, and now they're like, oh, now we have that diagnosis of endometriosis. Oh, we probably should have, referred earlier. But what happens if they got pregnant with their first IUI?
Yeah.
Right. What happens if they got pregnant with their first IVF transfer and they had endometriosis? Because so many of the patients do. Right. You have so many patients with endometriosis that end up getting pregnant with IVF and with IUI without ever needing surgery.
Not to mention the spontaneous pregnancies.
Yeah. Oh, yeah.
Which
and
we don't even see. Yeah.
Yeah. People are doing cesarean section for something completely separate. Then they find all this endometriosis, and nobody has ever diagnosed it before. And they got a spontaneous pregnancy and all these other things. Things happen all the time. But I think when you get to that point, right, we've had implantation failure. We've had people try IVF and they haven't gone to be able to get pregnant with a round or a couple of rounds of IVF. And maybe they have pain, maybe they don't. But this is the time I think that is really important to refer somebody, because if you refer them too early, our surgical wait times are long enough already. And if their goal truly is pregnancy, their best chance of pregnancy is going to be with you guys, not with me. Right? I'm tilting the scales just a little bit. You guys take the scale, throw it out the window, right? It's a totally different ballgame. And I think when people are like, oh, now I have my surgery and my transfer worked after my surgery, I wish I had my surgery so much earlier. So much easier to say that afterwards, because there's so many people who are in the opposite camp. And those are the people who have had the struggles with all of their fertility, where that little bit of change in the scale might make the difference. And that's when we're trying to make those incremental improvements to try and improve their chances of getting pregnant. And that's what might tip them from one way to the other. Whereas a lot of people don't need that little extra boost. So it's a question which is impossible to answer, and it's going to come patient to patient. But realistically, when I talk to my patients and I'm like, you've been trying to get pregnant, you haven't been able to get pregnant, you've had 6 months, you've been trying naturally, this is the time to go see a fertility specialist, right? You're young, you've spent a year trying, this is your time to go see a fertility specialist. Then you guys do what you do best. You get people pregnant, right? And then there's that select few people who end up having a really hard struggle with fertility, and they've done multiple fertility treatments. And that's when I think that those incremental improvements are so much more valuable.
No, that makes sense. I'm satisfied with your answer.
I'm glad I could satisfy.
And I, you know what, if anything, it's reassuring to hear that you feel the same way, in the sense that you never know in terms of how things can transpire, how things can go, and that there is no set formula or algorithm to say, okay, yeah, now you think about endo. And then again, as I said, always in the back of my mind, I'm thinking the wait times to see you versus ag reserve and time passing, right?
Yeah, I think that we have to tease out two things though, right? There's the people who have the pain and the fertility, and there's two different reasons we operate.
Yeah.
Sometimes we operate solely for the fertility benefit. Sometimes we operate solely for pain benefit. And sometimes those things are muddled in between. And we have to find that balance of when the perfect time to do surgery is. And, I have patients that you guys send to me after your very first consult because you see them and they talk about how horrible their periods are and how painful their periods are. And I end up seeing them pretty soon after you guys end up seeing them. Right. And those are the patients that we talk about operating on for pain benefit as well. And those are the patients who end up getting seen earlier because they're getting surgery for a different purpose. Right. Or an added purpose, not necessarily a different purpose, but an adjunct. Right. And those are the two main indications for surgery for endometriosis. And I think that if you only talk about one, it seems so black and white, but it's really not that black and white. There's a big field of gray in between. And that field of gray is all patient preference, right? That's all their choice. And you give them the information and they get to make their choices. We can guide patients, give them our expert opinion, but when it comes down to it, this is their life and their body, and they get to make that choice in terms of what they're going to do. We just arm them with all the best knowledge that they can have. And then they go and research online anyways.
You sound like a fertility doctor.
Maybe I'm hanging out with you guys too much.
Or they listen to a great podcast and learn everything they need to know about endometriosis.
Where you get your information is a huge importance.
Okay.
So I think the inverse of that question is really important for your listeners and anyone who has endometriosis or anybody who struggles with pelvic pain and fertility as well, which is what is the time where you as a fertility specialist think it's really important to send somebody for potential investigation of endometriosis or surgical management? We have a special relationship here where we can actually get the answer of endometriosis a lot of the time before we operate, which is really nice, which is not available in a lot of places. But I'd like for you guys to talk to that.
Well, for me as a fertility specialist, like I said, I always ask in my first consult about pain, both dysmenorrhea, which is pain with your menstrual cycle, and dyspareunia, which is pain with intercourse and pain with bowel movements as well. And obviously, we look at the ultrasounds as well for the obvious ovarian endometriosis that you might see on a regular ultrasound, not a mapping ultrasound. And then putting together the pain, the age of the patient, the goals of the patient. Do we want one child? Do they want two children? Do they want three? Do they have two already and we're looking for one more? Do they have none and we're looking for three, which means longer. I need more embryos. I need more time. And looking at their, again, age and their ovarian reserve, because time is of the essence when you're looking at those two things, how old they are in their ovarian reserve. Then there is a nuance, and we put it all together. If somebody is, let's say, 39 years of age, AMH level is medium, and they'll tell me they're having some pain, then we talk about, okay, let's make embryos, let's bank embryos, let's make sure that you can make embryos first that are chromosomally normal. Let's try to make 4 or 5 if possible. And then we can sit down and see after you go through IVF and you make embryos where you're at. So let's say you've made those embryos. What is the quality of the embryos? Were you able to make a lot of embryos? Where's your pain at? And again, like exactly what you said, the patients have to make a decision. And there's a discussion of, I know there's this condition called endometriosis. You might have it. You're having pain. You don't have a swollen fallopian tube. So we know it's not like an absolutely must that you need to have surgery. We know that the evidence is a bit murky in terms of implantation. You have these embryos. It could be that they have 1 euploid and 2 mosaics, or 2 euploids and 2 untested. I mean, there's a million combinations there. And then we have a conversation about, do you want to do a transfer next month? We would know if you're pregnant or you're not. And if you are, you never have to meet this guy called Dr. Zeni. Or do you not want to do the transfer? You present the same scenario to different patients, and different patients are going to give you different answers, because this is a very nuanced situation and everybody's on a unique journey. I had endometriosis as well. We're not going to get into my story, but I didn't have surgery. I wanted to be pregnant. So I did embryo transfer after embryo transfer after embryo transfer, because I knew, like I said, that's what's going to tip the scale, throw the scale out the window. I knew that endometriosis surgery was just going to help me like 5%, and doing transfer after transfer after transfer is going to help me a lot more to get to my goal. So I put up with the pain and I left endometriosis alone and did my transfers. But somebody else may not feel the same way. Somebody else may feel, no, I need to get to the bottom of it. I am uncomfortable proceeding without a clear treatment and diagnosis of endometriosis. And I'm okay to wait. I'm okay to wait for the referral and the consult and the surgery and put my embryos on ice. And I understand that there is a risk that when I come back into these embryo transfers, they don't work. I'm older. I had surgery. I might not be able to make more embryos. endometriosis surgery is always at the back of my mind, but it's really a conversation with the patient that takes into account all of those pieces. What about you, Dr. Weiss?
A lot of what I'm going to say is probably kind of similar to what you guys said, but basically, I agree. At a first patient appointment, I'm always asking about painful periods, pain with intercourse. And I agree. The vast majority of the time, people are like, I take a Tylenol here and there. It's not so bad. So I'm not necessarily thinking about endometriosis right off the bat. But again, if I'm seeing somebody for the first time and they're telling me, yeah, I'm in bed, debilitating pain, I need round the clock prescription pain medications, then I'm going to be thinking about endometriosis a lot sooner for sure, and the impact on fertility and pain as well, because I think that is also a really, really important factor. And I think you kind of spoke to that when thinking about why you're doing surgery. Is it more pain? Is it more fertility? Or is it both? And that might kind of change what your potential plan would be. But I think, let's say we do our initial investigations, we do an ultrasound. If we're seeing endometriomas present, then again, that tells me, yeah, this is somebody who has endometriosis. And then I will counsel them and say, listen, if you have these endometriomas on the ultrasound, that tells me that you have endometriosis. We know that with endometriosis, it can affect fertility in a number of different ways, but it doesn't mean that you can't get pregnant. And so then I present to them the option like, okay, we can potentially pursue doing referral to an endometriosis specialist, potentially surgery, but that this is what it's going to look like. This is the reality of it. This is what the timeline could be versus, maybe again, we start trying with something simple, something basic, something like IUI, depending on the sperm and the fallopian tubes and all the other things, where maybe we will get you to pregnancy. Maybe we don't need to do all of that. And then just revisiting it as things progress and as you move to IVF. If somebody has swollen fallopian tubes, so like a hydrosalpinx, then for sure, I'm definitely recommending surgery, at least the removal or interruption of the hydrosalpinx before an embryo transfer is done. If somebody's doing IVF and I know that they have this swollen tube, that is someone who I'll be counseling against doing a fresh transfer or making sure that the surgery gets done prior to an embryo transfer. And I agree. That is, though, the one thing that I think has the strongest evidence for when it comes to endo, when it comes to IVF, that we can kind of hang our hat on. In a situation where somebody most commonly what happens is someone who doesn't really have a lot of pain, doesn't really tell me about painful periods. We maybe do IUI, maybe do IVF, maybe you get to embryo transfer, potentially failing of euploid embryos or good quality embryos, even if they're untested, where I think it's time to circle back and answer this question and talk about. And so whenever anybody fails a euploid embryo transfer, I always talk about this question of pelvic inflammation, this question of occult endometriosis. I always bring it up and I say, listen, it's a possibility. It's absolutely possible. But finding out if this is really it is challenging, whether I will now be sending more people probably for endomapping ultrasound to you because I'm now a convert after hearing you talk about it. But this is the reality of the timelines and everything, and that you may be making more embryos in the meanwhile may be beneficial regardless, right? If somebody may potentially be ending up having surgery down the line versus trying something else and potentially proceeding with transfer. But I think it depends on the bigger family plan too, right? How many children is this person hoping to have in addition to, their current, the pregnancy we're trying to achieve now? What are the embryos like? What is their age? What is their egg reserve? These things are all going to be part of the discussion. I mention it after a failed euploid embryo transfer, this question of occult endo for sure, but I don't necessarily send everyone for an endometriosis consult.
After a failed euploid embryo transfer, occult endometriosis is only one of the many reasons why that could have happened, right? So we can change the transfer protocol, we can do immune testing, we can do biopsies, we can look at the embryo. Maybe the embryo was a euploid, but not all euploid embryos are the same. Maybe it was a day 6, maybe it was a day 7, maybe it had a low morphology. There's a million reasons why a euploid embryo transfer may fail, and the possibility of occult endometriosis is only one of many, if it is one of them.
Yeah, I think that that's really important to think about in like these circumstances. We're talking about endometriosis so much today, and we're not really hitting on, there's other reasons people have unexplained infertility or presumed unexplained infertility at the beginning, right? Endometriosis is just one piece of that puzzle. Now, Marta, you mentioned endometriosis mapping, and we're going to talk about passions like this is out there for me, right? I think it's such a huge game changer in terms of how we approach this disease, just from the beginning to the onset, to the counseling, to surgical planning to how long we're even scheduling people in the OR, who we're talking to beforehand. All those things are so important. But for you guys as a diagnostic tool, as this is going to become more and more accessible, this is our goal, right? Our goal is to train people to be able to perform these scans. These scans are not like a normal pelvic ultrasound. We're looking at structures that every other sonographer has always been trained to ignore, right? And a lot of them have never even been told that these structures exist. And I talked to some of the sonographers here, they were always taught that you can't see a normal fallopian tube. And I'm like, oh, look at this. This is the fimbriated end of the fallopian tube. We can make a wave at us on ultrasound. And they're like, this is crazy, right? We were always told that you can never see a normal one. You can only see an abnormal one. And there's so much we can see with ultrasound that was presumed that was always never going to be able to be seen. So when we look at these uterosacral ligaments, we look at the area behind the cervix, we look at this area beside the uterus, how everything's moving together. We look at the rectum, we look at the bladder, we look at the tubes between the bladder and the kidneys. All those things are things we assess with these ultrasounds. We get so much more information. And as we train more people to do this, it's going to become more accessible. And that's our goal. Our goal is to make it so that it's not only a select few people can have this done, but we're going to have more and more people who are going to have this available to them. And what do you guys think of as a time when you would actually request people to have these ultrasounds done within their fertility journey?
I think if access wasn't an issue, I think the dream is that it becomes the standard of care in the fertility workup.
Yeah.
For all
I agree.
patients.
And I think that not only that, but then the research subsequent to that, right? To say, okay, now that we're getting all this information, accurate information, good information about endometriosis, again, you said superficial, deep, and endometrioma, the size, the presence, whatever, and then following them out, because there is such a paucity of research in terms of actually understanding what the effect is, whether things actually have an effect, don't have an effect, whether it's the egg, the embryo, whether it's the embryo transfer, breaking that all up. And so I think that if in an ideal world, great if this became the standard part of the fertility workup, but then that subsequent research would be really, really powerful to help us figure out what to do.
Because the biggest problem that we've always had is you need a laparoscopy to diagnose endometriosis. It would make no sense to have somebody with 1 year of unexplained infertility going for a laparoscopy that has no symptoms at all.
Preach, Mavis.
Right? So if it's going to be a diagnostic, again, it's going to be done by somebody who cannot do the excision, because we're not getting into a specialized endometriosis surgeon like you. So having a mapping ultrasound in my dream of dreams would be for everybody, like part of the standard of care for anybody going through fertility at the beginning of their journey, so that we know what we're dealing with. Doesn't mean everybody needs surgery, but we know what we're dealing with. Then we can have a conversation that is not based on speculation about whether or not you have pain, speculation about should we take off 2 years waiting list to get to see a surgeon. It's like, we know what we're dealing with. Now, just like we always look at the sperm, the ovarian reserve, the axis of the ovaries, the age of the person, that's just the baseline. And from there, we build all the pieces of your plan. Yeah. So a mapping ultrasound should be part of that puzzle right off the bat.
Yeah. People talk about too much information. I don't think that in skilled hands and people who actually have the best interest of their patients, there's really such thing as too much information, right? This is information that right now we don't know exactly what to do with it, right? But we can have that conversation. And when other things come up, we have a bit of more of an idea of what's potentially contributing. Marta, I love it. Please, we need this research in terms of where are we going in terms of deep superficial endometriosis, especially in the fertility world with IVF and IUI, and being able to actually tease out how does it affect ovarian reserve. The ovarian reserve stuff is getting teased out better and better now, but all this deep endometriosis, superficial endometriosis stuff is so murky still that I think it's really hard for physicians, never mind the patient, right, to be able to grasp what exact effect this is going to have on the fertility journey. So I love it.
Yeah. And just to be clear, mapping ultrasound, it's not widely available yet. How long have you been doing this at Care Image and American Fertility?
Since August of 2023. So we're
like 6 months. And
not that long.
Not that long. And right now, it's only you who can do it. I cannot just order a mapping ultrasound. I have to refer them to you, and you have to do it. So we're not there yet in order to be able as fertility specialists do mapping ultrasounds in all patients. Just want to clarify that.
Yeah, we're not. I'm talking in like my ideal,
Yes.
Yeah.
Our ideal world. Yes.
how things are going to go, right? My ideal world is that people like me aren't the only people who can do this, right? Ideally, I'm one of many, many, many who does the mapping, and trying to proliferate these skills with both sonographers and radiologists or gynecologists who end up rating these ultrasounds is going to be super important. But we need to teach people, right? This is going contrary to so much of the training that's gone on and for such a long period of time, that you need people who are interested in doing more work and making less money. And that's a hard sell. So we're working on it.
Yeah.
We have some people here who are super interested, and it makes it so much easier for me, right? Because we do this so we can get the best care for our patients. And when we have other people who really appreciate that and buy in, it makes our lives so much better. And at Care Imaging here, I've had this amazing support from top down. They're an anomaly, right? This is not a normal thing. We are just so lucky and blessed to get this support. And Roger Stranell is an absolute gift in my life and gift for all my patients. I'm just so thankful for him and you guys and how we can all work together in all this. So it's great.
We have to make endometriosis mapping a reality, okay? That's our mission.
That's on our checklist.
That's right.
Yeah.
That's right.
Thank you so much for joining us again, Dr. Zeni. It was always a pleasure chatting with you, and we learned so much. And I really hope that this conversation is helpful and inspires patients to think about their own journeys and how it's not always necessarily straightforward in terms of managing endometriosis, and it's not black and white. But thank you for helping us navigate through that, Gray.
And I don't think you're done with us. You're coming back again. We'll find you.
Thank you guys so much for having me.
Thank you so much. The pleasure is all ours.
Bye, guys.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast, or visit us online at myconfertility.com. And don't forget, follow, subscribe, and share your favorite episodes.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.